Hi, and welcome to the Restorative Wellness Clinicians Corner, a video series exclusively for functional health professionals, where we interview the top experts in the latest research, products, tools, and best practices for getting your clients exceptional results. Hello, everybody. I hope you're doing really well and enjoying maybe the early days of spring, depending on where you live. We have been getting teasers of the warmer weather here in Boston, but I fear we still have some winter left before we really turn the corner. So hope it's warmer where you are. Today's episode is with one of my favorite humans, our very own medical director for Restorative Wellness Solutions, the esteemed Dr. Chris Turnpaugh, one of the OGs in the functional medicine space. In this conversation, Dr. Turnpaugh and I dig into a concept he's been playing with in his clinical practice, looking at how the body's toxin burden is increasing susceptibility to infectious diseases like Lyme, Long Covid, and so on. It was a really fascinating conversation. We did get into the weeds here a little bit. There's some real clinical gems in this one. If you listened to our episode a couple weeks ago with Dr. Evan Hirsch on toxins, fatigue, and recovery, this episode is a fantastic complement to that. Enjoy. Today, we are in for such a treat. We have our very own medical director, Dr. Chris Turnpaugh. Dr. Turnpaugh is a skilled, incredibly skilled practitioner whose primary focus is on finding and addressing the root cause of disease. He graduated from Life University and received his postdoctorate in functional neurology. His interest in functional medicine began with the intent on helping a current patient who was looking to address his whole health picture after an ALS diagnosis. Dr. Turnpaugh attended a seminar in 1995 given by Dr. Jeff Bland, the father of functional medicine, and that began his career in root cause medicine. So he's been doing this for a minute. His passion for functional medicine led him to open the Turnpaugh Health and Wellness Center in 1999. And he enjoys the overall care team approach and loves sharing his knowledge with his team, patients, and other providers. He has extensive experience in supporting patients who are dealing with the most difficult chronic autoimmune and neurological health conditions. He has a vast history of personal experience and consequently supporting Lyme disease, autoimmune conditions, thyroid disease, hormonal conditions, and more. He teaches providers across the country about blood chemistry, thyroid conditions, brain disorders, and other functional medicine training. And we are so lucky to have you here with us today. Dr. Turnpaugh, welcome.
Having me. Sorry for the technical difficulty.
No worries. I just want to say a little fun side note. A whole handful of us got to hang out personally with Dr. Turnpaugh in Arizona back in September at the Mindshare Leadership Summit. And our community of practitioners already loved you because of your clinical mind and incredible training. And pretty much every single one of them pulled me aside at some point over that week and going, oh my gosh, he's so amazing, everyone. So just like in all the ways, you are just a shining light in this community. And thank you for everything that you do.
Thank you.
So today we are going to be talking about a new concept that you have been playing around with in your practice. This idea of who is most susceptible to infections, particularly these like really serious infections, things like Lyme, Long Covid, recurrent Epstein-Barr, etc. Why don't you tell us what you've been seeing in your clinical practice?
Well, those of you that are familiar with the drawing that I put out, I think I've shared it with you guys. So you have these two sides to the immune system, Th1 and Th2. And the Th1 side is the side that recruits your natural killer cells and kind of helps that onslaught of infection and fights the infection. And the Th2 side is the side that kind of evades the immune system and allows it to kind of fester and leads towards things like autoimmunity and cancer and those chronic diseases. And what we find is that, first, when you get infected with a bug that's chronic, we'll pick on Lyme, for example, it could be anything, you kind of go to a Th2 dominant state. And that's a great way for the infection to evade that side that's going to kill it. So it's really nice for the bug to have this live in this house over here, which can avoid that immune system from attacking it and resolving it. And so when you're Th2 dominant, you're less likely to fight and attack that bug. And what we find interesting is that, doing a little bit deeper dive, is the world we live in with chemicals and pesticides and endocrine disrupting compounds and all the things that are toxic in our world, that actually shifts our immune system and swings it over to that Th2 side. So you're predisposing yourself immunologically to a side of the immune system which is not really the best at killing the bug. So if you have toxic burden, chemicals, pesticides, like I said, all those things, you're already shifting the immune system away from killing a bug. So you're more likely to then get a chronic infection that doesn't resolve. And you're less likely to resolve it once you do get the infection because you're kind of in that dominant state. So I think this environmental burden that we're placing on our bodies is leading to an increased susceptibility to getting an infection that doesn't resolve, and to follow that up to getting an infection, you just can't resolve the infection. And so now we have systems involved. We have, we can't resolve the infection, and the infection is trying to get out through things like gallbladder and bile, and the gut is already dominant. And so we see a lot of gut symptoms resulting in this. We're trying to kind of get out those toxins, which are, for lay terms, clogging up the liver, impeding bile flow, and just not having even proper digestion and then nutrient supplementation or nutrient intake.
So basically, body overburdened with the toxic burden that we already have. It was, we're all just so completely overwhelmed with this. Well, I shouldn't say we all. Actually, that's actually one of my questions for you. Is this something that everyone is dealing with since we're living in such toxic soup? But I'm going to ask that in just a moment. But basically, those who are really overburdened by the toxic environment and that we're living in, it is a certain type of person that has this susceptibility that's going to have those toxins drive that Th2 dominance, or is this something that's happening in all of us since we're all exposed?
Well, both. I think we're all susceptible, but there are some HLA-DQ genetic subtypes that are less likely to, they're more susceptible to infection. They're more susceptible to maybe mold or chronic Lyme. And there are also other genetic susceptibilities that have decreased detoxification pathways or conjugation pathways, elimination pathways. So there are some genes that do play a role in it. But it's, even if you have the best genes possible and you hit the genetic lottery, you're still in a cesspool of toxins that is going to burden your body. And I think this is why, at least over the 30 years of my career, 30 years ago, people were actually much easier to fix. And the toxic burden has built up and built up. And now we're seeing patients that used to be fairly simple. There is no such thing as simple anymore. And so you have to kind of go through all those clinical steps, and it's harder to meet that threshold of resolution in the world we live in today.
So what led you to this? Was it just sort of hitting your head against the wall? Because you specialize in working with these really complex clients, and you see, you are in, an area of the world where Lyme disease is rampant. What was it that started you kind of thinking down this pathway?
Well, luckily, I was very fortuitous because 30 years ago it was less of a burden. I'm sure it was a burden.
Right.
People. So I kind of evolved with the toxicity, and I said, hey, why aren't these people that were able to resolve before? What is different now?
Right.
What is really changing? And the bugs weren't. Maybe a little bit, but the bugs weren't getting stronger. Like
Right.
the bugs aren't getting stronger, but we're getting less resilient. So what has changed? Certainly, we know the food supply has changed. Our diets have changed, but even people that are eating clean and they change and they're eating better and following the steps that we all know, they just were still having this chronic insult. And we started looking into, which again, 30 years ago wasn't as big a deal. So, and we didn't have the advanced testing that we do today with all like the total tox burden and all those types of things, looking at these chemicals in our body. And I don't know that we had to 50, 70 years ago. They didn't exist as much. And so, and then you also hear the stories of, we have patients from Europe and they resolve quicker. They do better. We get patients from, these other countries, and they tend to just do well with the care that worked 20 years ago.
Right.
So we started asking the question, well, what's different? I mean, yes, they maybe it's a different lifestyle, maybe they're more active, but really what's the difference? And we started looking into the toxicity, and lo and behold, when we started to reduce the burden of toxicity, the patients from America were starting to turn the corner a little bit easier. And it's really a confounder, because in my world, no, it's not Lyme, it's mold. No, it's not mold, it's Lyme. No, it's not Lyme, it's gluten. No, it's really all of the above, and you just lose your tolerance to the world you live in, and then everything bothers you. And then you have the patients, it's EMFs, no, it's your cell phone, no, it's all of that, because we lose our tolerance. And if we shift over to that burdened side, that Th2 side, we lose tolerance to everything. And these are the patients that come in, they can't eat any food, they can't be around any chemicals, they can't be around any smells, they can't tolerate their spouses, they can't tolerate their children, they're just lose tolerance to everything. And where do you start? It's really they can't even eat a food, they can't take a supplement. So we just started to look and say, what has changed? And I think the biggest change isn't the strength of the bug or even the strength of the perfume. It's the strength of the chemicals that were and these pesticides and herbicides and chemicals from the burden of our water supply, our air supply. So people can't get around it. It's just, we say the air you breathe, the water you drink, and the food you eat. It's just ubiquitous.
So given that, it's interesting. I was going to ask you if there's any kind of hierarchy in terms of the toxins, and we hear and see a ton of mold, but I would guess that mold's not something that's new. It feels like that almost falls into the same category as like the Lyme and some of these other things that have been around longer, but people are a little bit more vulnerable to the ill effects of it. It's not that, so are there certain chemicals that you're seeing that you can kind of point to, or is it just sort of this kind of big bucket of everything else?
I think it really falls into the big bucket. So it's not the one chemical that's doing it. Like, they're not coming in just with arsenic poisoning, and they're not coming just bisphenols or plastics. It's, I'm shocked, but I heard a couple months ago that the average American eats a credit card worth of plastic a week. And now that doesn't mean it stays in their body, but that's an exposure that didn't exist. I mean, even though it wasn't healthy in the 70s, you got a bottle of soda and it was in a glass bottle that you had to pay 10 cents to return it because you got returnable bottles. That is something my children will never see, never heard of before. And it's just this total burden, I think, of everything, of the plastics and the air and the chemicals. So I think I don't know that it's one. I haven't teased out it's one more than another. And we have patients who they're on the West Coast and they can't go outside because they can tell when the neighborhood's spraying for roaches or they're spraying for weeds, and they can't go down the highway when they're spraying the highway for to kill the weeds, and they can't go to the ocean when it's low tide because of the residue from the high tide. It's kind of everywhere. And these aren't people that are they got really sick with one thing. They just have such a burden on their body that it just can't handle the load anymore.
So what do we do about this? Like, can you walk us through sort of how you're handling this? Because it's like all the things. So where do you start with that person who can't eat anything, can't take the supplements, is just feeling overwhelmed and is lost tolerance for everything? Are you running tests first? Are you walk us through how you're thinking about this process?
It is a little bit of a challenge, because when you run all the tests and you think you have the right treatment plan, but you can't implement it because they can't take what you're even going to give them. Yeah. So if you suspect somebody who has just a total toxicity burden, you can start without spending a bunch of money doing all the testing to kind of validate your theory. What can they handle? Can they handle NAC? Can they handle glutathione? Can they handle herbal bitters? Can we increase their stomach acid a little bit? So it's not always one approach. It's where's the crack in the armor. So a lot of the patients will maybe just use milk thistle at first. Maybe we'll just use some herbal bitters. Maybe we'll, whatever it is that we can get in their system to kind of start to get the flow out. First, can we clean up their environment a little bit, right? Because the body is naturally, if it's detoxifying, say 10 parts a day, but they're exposed to 100 parts a day, they're constantly building that up. If we can get that down to an exposure of 9 parts a day and an excretion of 10 parts a day, we're winning that battle. And then can we support those pathways? So some of these people, it's just where do we start? Can we clean up their environment? Can they sweat a little? Can they get in a sauna? What can they do to just get themselves less toxic every day and reduce their burden? And I wish I had, you start with this, and this is your entry point, and this is where you crack the can, and this is where, but it's different for everybody. These people, they're the most trying patients are the ones where you're kind of running out of options as to what to do. We do use, not everybody does this, but some people can. We use the VIP low dose nasal spray. So we make a nasal spray, it's a peptide. And if you do it in like 1 to 1,000 or 1 to 100 dose, it's a nasal spray. So we can bypass the gastrointestinal system, go right through the nasal passages. Now, I know not everybody has that at their disposal, but we're looking for anything, that it could be as simple as a sauna. It could be as complex as an IV. It's really challenging. How do we get stuff into them that supports the detox pathway? And sometimes it's just eating foods that support it.
Right. Are you thinking in that process as well about trying to shift that immune system balance over from the Th2 back to Th1? Are you trying to stimulate that Th1 pathway at the same time, or is that going to aggravate things?
Well, the aggravation is they usually can't tolerate what you're going to put in their system to switch them back to it. So, and these are patients, unfortunately, that we all kind of inherit that, they were sick, so they were on antibiotics, so now they don't have a healthy microbiome and they don't have healthy mitochondrial function because they were on antibiotics. And so we're kind of really are both hands tied behind our back because they're so fragile. There is one of the ways that can be done is you can use cidal agents or something that kills a bug, because by reducing the pathogen, you're also reducing that Th2 dominance. So can you reduce the pathogen? Can you use a natural agent to bring down their pathogenic load? Can you support them with something to clean out the toxins? Can you get their environment better? There's no great roadmap other than if you think of the nucleus as I'm Th2 dominant and burdened with an infection and or toxicity, where can I start? And anywhere you can get an entry point into that is where you're going to grab your foothold and start to move it the other direction.
Have you found that you're starting to get clinically better results now that you're really incorporating this toxicity piece in those, those Lyme patients, those long COVID patients?
I think we are. I know we are as a team. And so not everybody can't tolerate everything, but there's usually something they can tolerate. But, if we throw more at them, sometimes it's too much for them. So again, starting simple. Sometimes if you can't tolerate anything, maybe you can just do a vagal stimulation. Maybe you can have them gag and gargle. Just, maybe you can do something to stimulate the vagus nerve to jumpstart the digestive process to get some of those toxins out. Where the bile goes, the toxins follow. So anything we can do to increase that. Some people will just do literally a shot of olive oil to stimulate some bile flow. Anything. It's really anything. So, and when we started to think about this several months ago with our clinicians, we're finding that patients are resolving better without the use of antibiotics, with more natural things. So now most of our Lyme patients don't even use antibiotics to resolve because they're using this whole body system approach. So
Fascinating. I know these people coming in more of that chronic, long-term place or even acute.
Most of them are coming in a chronic state, but because they've heard that, oh, we deal with Lyme, they'll
Right.
chronic, and sometimes they'll do a short course of antibiotics. But typically in the Lyme world, you go on antibiotics for months and months and months, and we're typically a few weeks, and then we do dovetail it with cidal agents like something like cryptolepis and cat's claw for a longer period of time, but we're able to dovetail that and use less and less antibiotics. And we now actually, for patients, will have them keep something like cryptolepis in their house, and if upon a tick bite, they'll do a dose of it for 2 or 3 days, and usually the symptoms are gone. They don't even develop the symptoms. So it's kind of like the antidote before the symptoms start.
Right. Interesting. Um, when you're thinking about those sources of toxicity, and I love, thinking about kind of the order of things is something we're always focusing on because you've got to get the body ready to let go of some of these pieces. And so a nice place to start, as you said, is to identify and remove those sources of toxicity. How are you going about doing that? Are you doing something like, the total tox test to kind of identify the biggest culprits? Or are you just doing a bit more of an inventory of their overall life? I know so many of these things are invisible and, as you said, ubiquitous. So talk to us a little bit about that thought process.
Well, first thing we do is, are you continuously being exposed? So the easy one for that is mold, right? Are you in a water damaged building? So if you are, we have to remove the insult. Do you have an overburden of pathogen, which may require a cidal agent, natural or pharmaceutical? So do we want to reduce that pathogenic burden? Are you constantly exposing yourself? I mean, the easy ones, which I wish they were all easy. Oh, you're microwaving in plastic 3 times a week, or 3 times a day. Let's stop that. So if we can start to clean up areas of their life which are, we know there's no mold, we're reducing pathogenic burden, and we're reducing toxic burden load. That's a start. Then you can do a total tox panel, something like Vibrant has, where you can look at that. I think, and I digress a little bit, but by the way, this is so prevalent in female hormone issues. So
Right. Yes.
I have PCOS, but my insulin isn't high and my testosterone isn't high. Yeah, you're just having all of these issues because the hormones need to detoxify, and they're preferenced by all the chemicals that have to be detoxified. So cycles are off, and people are coming in with all the cycle issues and PCOS and weight gain, and these chemicals are classified as obesogens. So really looking at, they're coming in with one issue. Oh, I have acne, or oh, my cycle's terrible, or oh, I have weight gain, or oh, I have massive headaches. And you can just see that the toxic panel is prevalent. You can't even. The reason we detoxify isn't because we're supposed to have all these chemicals around us. The reason we detoxify is that we're toxic factories. We make our own toxins all the time. So that detox pathway was probably incorporated for us to detoxify our waste, not the environmental waste we're putting in. When you add the burden of environmental waste on top of that, we're clogging up our own factory detox pathways.
Right. You shared, when we were talking last week, you shared a really interesting statistic about the number, and I'm gonna mess it up, so I'm not going to try. But do you remember the statistic we were talking about? It was the people who had Lyme that had resolved. Let me see if I can.
Yeah, it was so 41. I don't know if this was it, but there's a bunch of numbers in my head. 41% of the people who had resolved from Lyme still have active Lyme. So if you get Lyme and you have chronic symptoms, 59% of those people don't have Lyme anymore, but they still have all the symptoms of Lyme. They don't have Lyme. 41% still have an active infection. So now you're taking more than half the people that are still complaining of the same symptom they had with the infection, although there is no infection present. Is that the stat you were talking about?
That is exactly the study I'm talking about. And so that you're explaining through this mechanism
Correct.
of it's that full, got it. There's lots of questions here coming in the chat, and they're really good ones. So I'm going to pop in. I'm going to go kind of back and forth between my questions and theirs. We have a question here. What is the correlation between long COVID and post-polio syndrome? And how do you suggest addressing this?
Well, so long COVID is no different immunologically than post-treatment Lyme disease. Post-polio is a little bit different because polio can actually cause some scarring or damage to what's going on. So if you have I have a post-polio patient who pretty much completely resolved through this methodology, but I don't want to make it sound like post-polio is going to be fixed, because if there's scarring, so to speak, or permanent damage to the nerves, then you may have residual side effects. But all these chronic, I had a disease and I'm not resolved, but the disease isn't there anymore, I would really think this way.
Right. David's asking, do hidden infections in the mouth, cavitations and root canals play a role in releasing toxic burden as well?
Huge. So especially people who have, like, the famous or very well established is, if people have root canals, they take the nerve ending out of the tooth, but they still have that pocket underneath there, which is a great pocket for bacteria to breed, toxins to live, especially if there's an entry point through the mouth. And not only toxins can live there, but also infections can live there. And if you've had a root canal, you don't feel it as much because the nerve ending is gone. So you have this low-grade breeding ground of infection that can go systemic. So I can't tell you the amount of patients, again, over 30 years. There's an old phrase there was a bunch of clinics in the 50s in Germany. Hans Nieper, famous guy, I don't know if everybody heard of him, but he had a sign in all of his offices. He had 13 offices, I believe, and it said, "Save the patient, pull the tooth." So I'm not recommending I'm not a dentist, but these are great places for breeding of toxins and bacteria to be. That doesn't even go into like mercury fillings and the oral hygiene and the bugs that live in the mouth, that if you have receding gums, get into the system. So the mouth is just a hog pen of places for bugs to live.
Absolutely. Is that one of your top things? Is that part of your clinical intake, inquiring about that?
Yeah, we ask about gum health and dental health. And, there's also, it's pretty well established that heart disease starts in the mouth. So, so just looking for those streptococcal infections. And, it's very common for spirochetes to live in the mouth. You can see them. There may not be Lyme, but spirochetes are basically in everybody's mouth. Well, if they stay in the mouth, it's great. If you swallow it, your stomach acid, if you have stomach acid, should neutralize it. But if you have entry points in through the gums, that's a great entry point for these pathogens.
The Clinician's Corner podcast is sponsored by Restorative Wellness Solutions, the premier clinical training program for health practitioners who want to learn how to finally get to the root source of their clients' health concerns and help them reverse complex health challenges and chronic illness. You can't afford to keep guessing. Your clients can't afford it either. Today's clients are sicker than ever before. Their health histories are more complex than ever before. And you simply can't deliver the results they crave or build the practice you desire without the right clinical skills. Enter Restorative Wellness Solutions' foundational course, Mastering the Art and Science of Gastrointestinal Healing, our clinically proven, systematic approach to restoring balance within the body that has helped over 1,000 practitioners transform their clients' lives, grow their business, and change the way health is delivered. In less than 12 weeks, you'll develop the clinical skills and confidence you need to help your clients feel better, faster. Learn how to work with advanced lab testing to identify food sensitivities and imbalances within the gut. Craft custom targeted protocols that truly resolve your clients' gut issues, and work safely and effectively with supplements to deliver consistently life-changing results. Visit masterguthealing.com to apply today. As part of your clinical process, are you trying to differentiate, in terms of symptoms. So many of the symptoms, as you just explained, you have all the symptoms of Lyme, but there's no Lyme present anymore.
Right.
So many of these things overlap. Mold and Lyme as well, also big overlap there. Are you digging in to sort of differentiate, or are you just kind of making more, sort of assuming that these things are there and just supporting the client? We have a question here, kind of along similar lines from Ananya, about when you have all of these different things going on. Is there an order? And I'm hearing you say, I know we're all like, please tell us what is the step-by-step process, right? And I know that that's not always that simple. But are there certain things that you would, we're always trying to make sure that the body is strong enough to actually support eradication, or to go to these deeper levels, and that we've identified and removed the sources that are burdening it as much. It sounds like that's a key part of your process as well. But what are some of the are there key steps that you make sure, almost like milestones, that you want to make sure the individual is at before moving to the next step?
Yeah, so I think it's important when you have these to rule out what the source might be. So is there mold in the house? Is there mold in the work environment? Testing for that.
Yeah.
And
Do you have a favorite test for mold?
yeah, we use EnviroBiomics number 7. So
Okay.
EnviroBiomics is probably one of the best, if not the best, testing. It's very simple. Number 7 does the Hertzsmead-2 and the actino and endotoxins. And you get a kit. Actually, I have a kit here because I'm going to test my own office. Comes in a FedEx bag. I never do this, but other people do. You have a questionnaire. And what you get are little Swiffers.
Okay.
And there's a specific way you Swiffer. You go one direction, right to left, or left to right, but never back and forth. You don't right over the mole. You don't go over like mold, but you go over highly susceptible areas. And I think it's only like $499. And you can get a Swiffer kit, or if you have a lot of carpet, you can get a vacuum bag. So you vacuum up and it collects the dust in the bag, if you will. It's EnviroBiomics, and it's number 7. They have a whole host of tests to do, and that will cover it. So in people who are suffering from water damage building toxicity, only 7% of those people are from mold, and 40% are from the bacteria Actinobacter that grows with it. So you want to make sure you don't just do like a Hertzsmead-2 or just a mold test, because it's the bacteria that's more common. And just to go down a rabbit hole here, when you're exposed to, like the whole Ritchie Shoemaker protocol, but when you're exposed to these biotoxins, you'll turn on gene expression, and that gene expression will maintain in the absence of the mold. So you have a mold exposure, you remediate the mold, and you don't resolve from your symptoms because you changed your gene expression, and then you become what takes the hit is the mitochondria, and you become what's called hypometabolic. And these are people that eat like 400 calories a day and don't lose weight. They feel terrible. They just don't resolve, even though that the mold is gone. But so anyway, I digressed. The first step is there presence of a biotoxin from water damage building? Are we sure that the infectious agent is remediated? And for things like Lyme, my favorite test is Galaxy testing, and they do it's a urinary test called a nanotrap. And so what you do is you collect their urine, and if Lyme is present, with the exception of it being only in the brain, because it won't cross the blood-brain barrier, it stays in the brain. If they're having these symptoms, what Lyme will do is it'll come out of the tissue, and it gives off what I call rocket flares. It kind of gives off outer shell proteins. And what it does, it sends off like an antigen, and then the antibody binds to that, but not the actual bug. Right. And so the antibody can't resolve the infection, but those all collect in the urine, and you can test the urine for true antigen. And if the antigen is there, the bug is there. If the antibody is there, you don't know if it's a previous exposure or a current exposure. So this is what they call direct detect. So you're directly detecting the bug. And they also have, so that's really great. We use that quite a bit for people who come in and they swear they still have Lyme because they have all the symptoms of Lyme. And my joints hurt and I feel terrible. And it's not just neurologic Lyme. And then so we do the nanotrap from Galaxy. And if it comes back positive, and it does, then we know there's active infection. That's 41%, right? But
Right.
9% of the time it's negative and it's not Lyme, and the more sidle agents aren't going to fix that. They do, it's expensive, but they do a Bartonella triple draw because Bartonella cycles in and out of the blood every 2 to 5 days. So you draw them like on a Wednesday, a Friday, and a Monday. And they're looking, they have a what's called digital PCR, because PCRs never find these things, but digital PCR does find them. And so they'll run digital PCR. So if they come back negative on their 3-day Bartonella test and or their nanotrap, we know it's not BART, we know it's not Lyme. If we test their house, we know it's not mold, we know it's not the bacteria that grows with mold, right? So now at least we know it's not an active infection, because we're using direct detect, not antibody detect. And then we can start down the road of and these people, these patients or clients will swear to you they're still infected because they feel the same exact way they did when they were sick with the infection. So the first thing is, are you exposed or do you have an active infection? So that's important. And then after you rule out that it's not an active infection or an exposure, you can start to then say, and it will resonate with them if they're not married to their disease, which a lot of them are. Like, I have Lyme, I'll always have Lyme, I'll never get over Lyme, that's just Lyme. Then we can say, well, your body is expressing itself in Lyme. And I use this story, and all my clinicians stole my story, which I don't care. But I had a patient with a bullseye rash from a tick bite on their deltoid here. And every time they ate gluten, their symptoms came back, and so did the bullseye rash. So the bullseye rash came back. Now, there's no antibiotic on the planet that's going to kill gluten. But gluten caused the same exact symptoms with the same exact findings that the tick did when the tick bit the patient. Right. So everybody uses that story because it's very easy for a patient to say, oh, they got the rash back? Yeah.
So fascinating. So fascinating. Okay. Question here from Deidre. Are there cases where you address Lyme and co-infections before addressing the toxic burden? Like, in that, is it just an acute presentation? She says, I'm seeing in many cases addressing toxins put Lyme into an asymptomatic presentation as well.
Yeah. So what you're doing by reducing the toxic burden, really what you're doing is you're fighting the infection by allowing the body to fight the infection with natural killer cells and Th1, which is the ultimate goal. So
it's all about relieving the pressure on or it's all about alleviating that Th2 dominance and allowing the immune system to come back into balance, which is the theory behind all of this. Got it.
Toxic burden. You can also get there by, not that we do, but you can also get there through antibiotics and reducing the burden because you're stimulating Th1 and killing the bug. So
wonderful. The study that you quoted, would you be willing to share the link to that with the Lyme with 41% where they still have it? And we can include that in the show notes, getting some questions of people wanting to dig into that.
So after tonight, I don't have a computer. So as soon as I get my computer,
we blew up Dr. Turnpaugh's computer with our podcast software.
Well,
I'm sorry.
Usually too, I don't know if you've ever seen my computer, but I have like 40 tabs open because I can't lose a tab because I think they're all dire, and so they're all gone. So I have it. It's actually in a presentation I recently did, so I can get that to you. Yes.
Okay, brilliant. Thank you. How do you feel about fish testing for direct detect?
Yeah, fish test.
Is the nanotrap better or as accurate as that?
So fish testing, when you're doing this immunofluorescence and you do fish testing like IGeneX does, the way I'll describe it to you is it's a very low throughput. And what I mean by that is a fish test needs to be done on immunofluorescence on a slide under a microscope. And so, you have to get it in that droplet of blood and see it on that. What they do with the digital PCR relative to the Bartonella testing is the digital testing, instead of a PCR, is like you take your blood and you amplify any DNA in the blood, and then you run it through and see if you catch any DNA of the Borrelia bug. What the digital does is it separates it into 20,000 other piles. Then it will, at that point, they magnify it. So it has a magnitude of increase in findings, because that fish test, while it's great, you have to catch the right slide that has that droplet in there. But if you get a positive fish is called a direct detect as well. You're directly detecting it. The challenge with fish too is with the immunofluorescence, really challenging to identify the exact bug. You more get the genus level, you don't get the actual down what kind it is. So it's hard to, if you capture a fish, it's a direct detect. If you capture PCR, it's a direct detect. And if you do antigen, it's a direct detect. So if you get a fish test for BART, lucky you, because it was on that droplet of blood. But if you do the triple draw with the digital PCR, you have 20,000 chances, like looking under the microscope 20,000 times for a fish test. So one's not necessarily better than the other, but if you're looking for probabilities of finding that needle in a haystack, you're going to find it 20,000 more times in the digital PCR testing.
Right. One of the questions that was submitted before our conversation tonight is asking, why do all Lyme patients end up with long COVID? Which to me begs the question, is that in fact the case that all Lyme patients end up with long COVID?
So patients with long COVID, they'll have exacerbations of all previous infections because they're stuck in those biofilms. They're kind of trapped in the biofilms. And then when you get long COVID, you get everybody talks about the cytokine storm. This isn't a new phenomenon. The cytokine shift is what drives the Th2 dominance. And so when you get this privileged position for the bug in a Th2 dominant situation, there may have been the cards may have been stacked in their favor anyway, because they may have been slightly Th2 dominant from the previous Lyme, and the COVID just knocked them over that way. So now they're really Th2 dominant. And so long COVID and post-treatment Lyme disease, to me, it's basically the same mechanism of immune dysregulation.
Right. I mean, really, everything comes back to this mechanism when we're in this. That's kind of the whole point here. In this, are you supporting? I know, having talked with you about this kind of stuff at length and taken many of your courses. Are you focusing at all on those beautiful Tregs that are helping to bring balance in here? How are we fitting that piece into the equation?
Well, the Tregs are super important, and there's two ways to address this. If you drive Tregs, theoretically, too quickly and too robustly, Tregs inhibit Th2, but Tregs also inhibit Th1. So you want to, if you're pushing it over, you can use things like we've talked about before, like Perilla. The Perilla shifts away from Th2 dominance towards Th1 dominance. Quercetin, which they use in long COVID and we use for, by the way, allergies, which is a Th2 dominant phenomena, works for that. So you kind of want to shift them from Th2 towards Th1. And the last piece of that, and I think you'll do fine if you shift towards Tregs or Th1. I think both are important. So things like glutathione and vitamin D and love and appreciation and care and compassion go a long way, which can support Tregs. So you just want to do anything to shift that preferential differentiation to Th2.
Okay. Are you ever actually testing within the immune system itself to see and kind of confirm this Th2 dominance? Or are you assuming that is the case? Like, you actually running labs for this piece of the equation?
Yeah, it's a great question, because some labs do it. I know Cyrex does it, but I didn't find it to be super helpful, because what's going on in the blood may not be going on in the microenvironment of the tissue. The classic example of this is cancer's Th2, Th17 dominant. And you can run labs on somebody that show they're Th1 dominant. But I have a patient whose husband is the chief medical officer. He's an MD, PhD immunologist, so he's intimidating to talk to. And he's looking at their whole approach is the same approach we're discussing now, Th2 dominance. And they're doing microenvironment testing of cancer tumors, which is not the same as the macroenvironment, which may be in the blood.
Fascinating. Fascinating. I never even considered that component. So recommendations of dosing on some of these agents you're talking about. She's asking specifically about perilla and quercetin.
So it's the age-old question, and I hate to give the age-old answer, but it's the amount of water that it takes to put out the fire. So I think the biggest mistake a lot of clinicians make is they don't dose hard enough. So, yeah. I mean, it's just there's not too much perilla or too much quercetin. It's usually not enough. So, if you're whatever brand you use is take 1 capsule twice a day. Early on for the first 2 weeks, I might have them take 4 capsules 3 times a day. I mean, it just takes it depends on the level of that dominant shift and constant pushing towards Th2. So I would my phrase that I use in the office is we drink out of the fire hydrant so that we can drink out of the water fountain. So it's going to be a lot in the beginning so that one day you just don't have to do a lot.
Right. Question here from Anne. She says she's worked with many clients with alpha-gal, even those that have tested negative but have all the same symptoms, and it always came down to toxin burden. So I'm assuming that that's going to be the same phenomenon as we're talking about here. Are there specific toxins that you feel have more of an influence? For example, something like glyphosate or heavy metals, or are you seeing some heavy hitters, let's call them, that are kind of rising up? Or we talked about kind of the big soup, so it's going to be all of them, but are you seeing amongst those some that have a greater impact than others?
So I think the ones that have the highest potential for exposure, like glyphosate, for sure, is going to be one. I think when you get an exposure to a heavy metal, the heavy metals just seem to have a stronger impact. I think it's less likely that it's the heavy metal burden, but if it's there, it carries much more weight. So if they're having heavy metal toxicity, it's going to carry more of a weight of that shift than, say, a little bit of this toxin, a little bit of that toxin. If you're getting mercury or arsenic and you have it in loads that are 2 standard deviations from the norm, that's going to do the same as like a multi-toxic situation.
I want to shift a little bit to think about kind of more from a prevention angle. And I know a lot of us have these clients who are so sick and coming to us kind of desperate, but then we also have people who are wanting to do all the right things and make sure that if they get COVID, it doesn't turn into long COVID. And if, that their bodies are resilient. And I'm sure all of us here are thinking like, how do I make sure that I'm not just Th2 dominant and like so susceptible? So are there things that you recommend that we be thinking about even with ourselves and those clients who aren't necessarily in this kind of desperate place to, help bring and restore more balance to the immune system, stop driving that Th2 pathway so significantly?
Yeah, so I think that the important thing is to have enough glutathione in your body, right? So you can use either a liposomal glutathione or just NAC that can convert over to glutathione. I think that's critical. And I think vitamin D levels are critical. And throughout COVID, there was study after study after study that said people with low glutathione levels, had worse outcomes. People with low vitamin D levels, they had worse outcomes. And to everybody here, we're like, duh, of course, because you don't have proper immune balance. I think those are 2 critical steps they're the first 2 things that I would think of. If I was stranded on a desert island, if I was stranded on a desert island and they said, what supplement would you take with you? I would probably be eating clean food because I'd be eating on a desert island. I would probably get enough sunlight because there's nobody on the island and it's sunny, so I'm running around half naked. But I would take NAC. That'd be the one thing that I took with me because it produces glutathione, which is the body's bodyguard, protects us against all oxidative stress, improves the P450 pathway through the liver, helps to naturally chelate out toxins out of our body, protects our brain from insult, protects our liver. So I think those are just everyday things that my kids have taken since birth.
Right.
So
I love it. A couple last questions here for you. So, and we think, I would add to that too, of course, we're always thinking about how can we minimize our toxin burden, you know, as clean water as possible, as clean the air as possible, making sure that, you're not living in a moldy environment, that you're minimizing plastics, all of that kind of stuff. Are there any prevention strategies for things that we feel a little bit more random, like ticks, like COVID, like some of these infections, to try to prevent them from taking hold?
Well, just like I think every household should have an EpiPen, because by the time you need an EpiPen for anaphylaxis, you can't call and get one at the pharmacy. You need to have it in your house. I think everybody in a high endemic area should have a bottle of liposomal cryptolepis. I just think,
Cryptolepis, is this for the Lyme?
yeah, for Lyme. I mean, if you have a bottle, we prefer the Quicksilver brand, Crypto.
Okay.
And, upon a tick bite, you want to take a couple pumps a day, 2 to 4 pumps a day for a couple days, just to prevent it from spreading, and kind of getting after it before it burrows into the tissue. So it goes bloodborne first, and that's when it's most susceptible. It's not even detectable on most tests for at least 2 weeks, so you don't want to give it that 2-week head start.
Right.
On exposure. The other thing we love is, I think it's called Ben's something, but it's basically cedar oil.
Mm-hmm.
Ticks don't love cedar oil. It's non-toxic, so you can spray your pants and legs with cedar oil, and you can do tick checks. So the longer the tick was on and the more it's embedded, the more harmful it is, the more likely it is to regurgitate its stomach into your body. So I think that's important. So, we have cryptolepis in the house. Most of my patients who have been concerned about it, they have a bottle sitting on their shelf just upon an exposure. And I can't tell you how many potential fires we've put out by using cryptolepis. They don't need an appointment. Just take your cryptolepis for a couple of days. If you have symptoms later on, let me know. But most of them don't. It doesn't matter. And then we'll ask them to send their ticks off to get tested if they pull a tick out, just to see what was in it. And cryptolepis is nice because it has carryover for, first of all, cryptolepis works on most parasites. So Babesia is a bloodborne parasite, so it works on Babesia. It works on Borrelia, Burgdorferi, and it has some carryover, not super strong, but pretty strong on BART. So you hit your 3 Bs. Your anaplasmosis and ehrlichiosis live in the blood, so you have good coverage from that. So you kind of like, I don't know what it is, but I'm going to use cryptolepis. Yeah.
Right. That's a fantastic tip. Thank you so much. Are you recommending anything? I feel like people have now kind of calmed down a little bit about COVID, but are you recommending anything along those lines? There's lots of respiratory gunks and stuff going around.
So for respiratory, it's really hard to, we try to reduce the inflammatory burden. So even just your anti-inflammatories like turmeric, curcumin. I still love perilla. I've said that perilla is used in Japan as a pharmaceutical for upper respiratory. I love that. Quercetin. Quercetin is a T cell regulator and also fights the Th2 dominance and helps. It's the flavonoid that Singulair was based off of. So, I mean, it's good all around. So those are the big ones. You can use zinc. Zinc is a nice antiviral replicator. So you can use zinc short term. You can use even things that have been used since 1904, like vitamin A. Vitamin A is a natural antibiotic. So you can use high dose vitamin A for a couple days. It is fat soluble, so you don't stay on it for very long. But we have so much in our natural arsenal to go after these things. I mean, vitamin A was the cure for measles in 1904.
Wow.
And it was published in the Merck manual on page 4. Use vitamin A for measles. Now, of course, it's gone from the literature, but vitamin A works very, very well as a natural antibiotic as well.
That's wonderful. That's wonderful. I'm aware of time here. Any last recommendations that you would make? You have an audience of clinicians here. Anything that you want to say, just sort of words of wisdom for them, thinking specifically about these really sick, complicated clients that can feel so defeated themselves, the clients themselves, feeling so kind of frustrated and defeated. And it can feel really defeating as a practitioner where all you want to do is help them. And it can feel like there's so many stones to turn over that it's just daunting. Any words of advice and wisdom to pass on?
Well, I just saw something from one of my colleagues, Detox, and he put something out and he was like, you know what? And it's so true. I don't know how he reduced it down, but are these patients going to have dysbiosis? Yes. Are they going to have food intolerances? Yes. Are they going to have multiple chemical sensitivities? Yes. So you kind of want to know that going in rather than spending all their resources on testing. If they spend thousands of dollars on testing, they don't have that thousands of dollars on correcting. And there's no wrong entry point. So if you start with reducing toxins and you're doing detox, great. If you're starting with barrier protection and cleaning up the microbiome and that's your focus, that's still good. It's whatever way you can crack the egg and get into the entry point. So I think everything that you guys all teach at RWS is the right method and just trying to layer the next piece on, and whatever your best clinical acumen is, maybe start there. So if I'm great with detox, good, go with that. I'm great with gut, go with that. I'm great with food, and go with that. So whatever, I think knowing though, even though, in a phrase I use a lot in the office, being directionally correct, even if it's incomplete. So you're directionally correct, but incomplete. No, there's just more to the story, but you're not wrong. You're not wrong in your direction. So I think the more complicated patient you get, the more likely they're going to have a positive test to whatever you're testing. Oh, but they have a positive oats, but they have a positive stool sample, but they have yeah, no kidding. They're going to have positive everything because their whole system is broken down. But what does that really mean? And just kind of look at them and say, we're going to just peel back the layers of the onion. And even if you don't get results in the first week or 2 or 3 or 4 or 6 or 8 or 10, you just need to have the confidence that you're directionally correct, and you'll get there at some point.
That's really great feedback. Really, really great wisdom. Thank you so much for everything you do and for sharing so generously all these. And I feel like this has been clinical pearl after clinical pearl after clinical pearl, just so invaluable.